Today we are going to discuss about an autosomal recessive disease. So guess what? Is it phenylketonuria we are talking about, or is it sickle cell anemia we are talking about, or any other autosomal recessive diseases? What you thought we are talking about? So I will give you a clue. This is related to hemoglobinopathies, right? We have thalassemia and we have sickle cell anemia. So we'll discuss in this video about sickle cell anemia, right? So to make this topic interesting, why you need to understand sickle cell anemia means, so sickle cell anemia will cause various effects, okay, right? Like in lungs it may cause sickle cell chest syndrome, pulmonary arterial hypertension. In CNS it may cause subarachnoid bleed, epilepsy, and stroke. Cardiac, you will see sickle myocardium, cardiomegaly, transfusion iron overload, splenomegaly, okay, uh, hematuria, enuresis in the renal system, and priapism, okay, in males, okay. And in eyes you will have background retinopathy, polyretinopathy, vitreous bleed, right? In liver you will see hepatic sequestration and gallbladder cholelithiasis. In fingers you will see dactylitis and vertebral collapse. So and still many more effects, right? So for this, to understand how these effects are occurring, so why there is stroke, why there is bleeding, why there is vitreous bleed, why there is retinopathy, why there is sickle cell chest syndrome, why there is arterial hypertension, why there is hepatic sequestration. So we need to understand these effects. So if a patient suppose came to you with these like chest pain or any hepatomegaly on eliciting on examination, otherwise he may come with stroke, then you need to differentiate this sickle cell disease also, right? So and in pregnancy, what affects the sickle cell disease will cause. So this is in pregnancy you will see painful crisis, thrombosis, and placental failure, right? So how this is affecting, so we need to know. So this is very funny diagram I made, right? uh, it's okay, let's discuss, okay. So normally we have hemoglobin, we have two alpha chains and two non-alpha globulin chains, right? So alpha chains will be produced from the genes which are located on the chromosome 16, and beta gene, for the beta gene, for beta globulin chain will have the genes which are located, the alleles which are located on the chromosome 11, right? So hemoglobin F means HbF, which is a fetal hemoglobin which has high saturation to the oxygen. Here the two non-alpha globulin chains are gammas, okay, gamma 2, two gamma chains will be present. In HbA, we adults will have alpha 2 and beta 2 chains, right? And okay, hemoglobinopathies will have sickle cell anemia and thalassemia. Sickle cell anemia is a qualitative defect, means qualitative means there is a change in the structure of the amino acid chain, right? Amino acids. So these codons, due to the mutation in a codon, or there will be change in the valine amino acid to the glutamic amino acid at the sixth position. So qualitative defect, it is an autosomal recessive disease, right? We'll see HBS, pure homozygotes for the sickle cell disease, and another one is heterozygotes, means they will have one allele is HBA and another one is HBS. So this is known as sickle cell trait, okay. It is resistant to the falciform malaria due to the sickling, okay. So pathogenesis, HBS, this sickle trait when get deoxygenated in if we climb high mountains, high hills like that, there partial pressure of the oxygen gets decreases, and decreased oxygenation to the tissues. So there is a deoxygenation occurs, so which leads to polymerization of the HPS. They form pseudo-crystalline structures which are known as tactoids, right? These tactoids, they distort the red cell membrane, form the sickle shaped cells. These are the sickle shaped cells. So if oxygenation occurs, then this will be reversed. So but chronic deoxygenation may cause irreversible sickling of the cells. Okay, increased sickle cell hemoglobin, increased tactoid formation, which are pseudo crystalline like structures. Hemoglobin F inhibits the polymerization, right? So what are the clinical features? We will have mainly 5. So why these clinical features are occurring? These are occurring due to the sickling. Sickling causes hypoxia. Mainly what will happen? We have reticuloendothelial system, right? So in that we'll have spleen, liver, bone marrow. These are forming the reticuloendothelial system. So these RBCs, after they complete the lifespan, they will go and destroy in the spleen, right? The diameter normally 7 micrometer. So the canaliculi which are present in the spleen diameter is 2 micrometers. Due to the elasticity of the RBC, they can easily pass through the splenic canaliculi. So they won't get destroyed by the spleen when they are young. After completion of the 4 months, which is lifespan of the RBC, these RBCs get old, the elasticity they get lost, so they can't adjust the diameter, and they get caught by the spleen and they get destroyed in the spleen, right? So what are the clinical features? We will have painful vaso-occlusive crisis, stroke, which is a silent presentation. If the patient or child comes with a silent stroke, we will give hydroxycarbamide to reduce the chance of the death. Okay. Sickle cell syndrome, bone marrow infection, which may cause fat embolization. Okay, in the to the lungs. Okay, to the lungs. It's due to the sickling, and these sickling RBCs may cause infraction in there also. So further sickling may cause ventilatory failure in the heart. Another one is aplastic crisis due to the parvovirus B19, which is self-limiting red cell aplasia. Profound anemia may cause due to the aplastic crisis. And another one is sequestration crisis. Before only we discussed, there will be in sequestration crisis, there will be massive splenomegaly and hepatomegaly due to the rapid sequestration of the RBCs and destruction by the spleen and the liver, right? So these we are discussing that old RBCs will get destroyed because they can't adjust the diameter of the splenic canaliculi, and this also these sickle cells also they will get easily caught up by the spleen and they get rapidly destroyed by the spleen. So there will be massive splenomegaly, which is discussed in the sequestration crisis, right? Another state is pregnancy. So in pregnancy, the presentation is painful crisis, thrombosis and placental failure. So how you will manage? You should counsel the patient first of all, preconceptional counseling. So you should ask for vaccination status, because pregnancy is also immunocompromised state, and this sickle cell disease is also more prone to many viral infections like aplastic crisis may occur. Okay, right? So we should test the partner. Folic acid we should give 5 mg high dose. In pregnancy also we will give folic acid, but before pregnancy also we should start the folic acid. Hydroxycarbamide, if she is using, we should discontinue the hydroxycarbamide 3 months prior to the conception. AC inhibitors discontinued prior to the conception. Pulmonary hypertension, placental failure may cause increased risk for the intrauterine growth retardation and preeclampsia. Aspirin 75 mg you should give. Thromboprophylaxis after delivery is low molecular weight heparin 10 days post vaginal delivery. Okay, after 10 days after the delivery you should give low molecular weight heparin, and 6 weeks post C-section. Transfusion cross matched RBC for okay, If there is any RH incompatibility, you should check and you should transfuse the blood. Okay, in investigation CBP blood film, you will see target cells and the sickle cells. Should do sickling test also. Sickling test, what you will do, you will take the RBCs and you will add sodium dithionate. If they are the RBCs are sickled cells, then the solution will get turbid. You will see some bubbles coming from the solution after like 1 hour of settling of the RBCs, right? So you will do electrophoresis for seeing the HBS predominance is there or not. Management, folic acid you should do 5 mg, and high dose folic acid you will give. And management of hyposplenic state, due to the various infections will get no, so you should manage that state. And seasonal vaccination against the influenza you will do. Vaso-occlusive status, you will give excess rehydration and oxygen therapy, and adequate analgesia you should be giving. And